I want you to imagine, just for a second, a highly advanced regenerative medicine, like the kind of treatment that can actually repair damaged nerves, rebuild collagen, and grow entirely new blood vessels from scratch.
Right, which sounds incredible.
Yeah, it does. But now imagine that this treatment isn't manufactured in some, multi-billion-dollar pharmaceutical lab. It is actually flowing through your veins right now. Today, we're doing a deep dive into the fascinating and honestly somewhat chaotic world of platelet-rich plasma, or PRP.
It really sounds like pure science fiction, when you first hear about it, but
Yeah.
it is a very real, very powerful biological tool. We're talking about extracting a patient's own blood, isolating the specific components responsible for healing, and then reintroducing them to target areas in these highly concentrated doses.
Which triggers massive cellular regeneration.
Exactly. The potential here is staggering, but as we're going to see today, it's not quite as simple as just moving blood from point A to point B.
Okay, let's unpack this, because our mission in this deep dive is to look at how this liquid gold, spun directly from our own biology,
Right.
is completely revolutionizing two major areas. We're looking at women's intimate health and fading fertility.
Hmm.
But we're also going to look at the dark side of this boom. Because the quote-unquote drug is just your own processed blood, this explosion in regenerative medicine has created an absolute wild west of unregulated cosmetic procedures.
Hmm.
And governments are now scrambling to control it.
Yeah, they really are.
So to get to the bottom of this, we're pulling from a really revealing stack of sources today. We've got clinical guidelines from a prominent women's health clinic detailing sexual function treatments. We have a massive systematic review analyzing PRP's use in vitro fertilization, and a really comprehensive UK government consultation response about the strict new licensing of non-surgical cosmetic procedures.
It's basically a perfect storm, biology colliding with bureaucracy. Because on one hand, you have autologous procedures, meaning the donor and the recipient are the exact same person. And these are changing lives, offering hope where there previously just was none. But on the other hand, the science, and definitely the commercialization of that science, is vastly outpacing the safety regulations.
So let's start with the biology, because understanding the underlying mechanism is kind of crucial for everything else we're going to talk about today.
Definitely.
I like to think of your body as a massive construction site. When you suffer some sort of tissue damage, the platelets in your blood are essentially the site foreman.
That's a great analogy.
Right, they're the first ones to show up at the scene of the injury. And they don't do the actual building themselves, but they immediately start, shouting orders and directing the growth factors to begin repairing the damage.
Yeah, to harness that, the clinical process starts with a pretty standard blood draw from your arm, usually around 20 to 30 milliliters, and that vial of blood is placed into a centrifuge. The centrifugal force separates the heavy red blood cells, which kind of sink to the bottom, from the yellowish plasma at the top, and suspended in that plasma are the platelets.
So the clinician is basically trying to extract just that highly concentrated serum of platelets.
Right. And when that serum is injected back into a specific target tissue in the body, those platelets undergo a process called controlled degranulation.
Which means what
They
exactly?
basically break open. They release this huge payload of powerful growth factors. Specifically, we're talking about proteins like VEGF, PDGF, and TGF-beta.
Okay, I actually saw those acronyms all over the clinical guidelines, but what do those letters actually do to the tissue being treated?
Well, they act as biological command signals. So VEGF, for instance, that stands for a vascular endothelial growth factor. Its primary job is to stimulate angiogenesis.
Which is the creation of new blood vessels, right?
Exactly. The literal creation of brand new blood vessels from pre-existing ones. Then you have PDGF, which is platelet-derived growth factor. That one signals the cells in the surrounding area to rapidly multiply and divide, which accelerates tissue repair.
Wow.
And TGF-beta, or transforming growth factor beta, is like the master regulator for the extracellular matrix. It literally commands the tissue to ramp up the production of collagen and elastin. Yeah.
So
So you aren't just, masking a symptom.
Mhm.
You're actually instructing the tissue to reverse aging and repair structural trauma at a cellular level.
Right.
Which brings us to how this is being applied clinically, specifically for women's intimate health.
Yeah.
One of the most prominent off-label uses for PRP right now is a procedure commonly known as the O shot.
Yes, the OSHA.
Clinics are using this to treat issues that a lot of people suffer from but rarely talk about publicly, like reduced sexual sensation, vaginal dryness, anorgasmia, and even mild urinary incontinence.
And the sources point out that these issues stem from just a myriad of factors. We're talking natural aging, physical trauma from childbirth, the side effects of SSRI antidepressants, and a major one, which is genitourinary syndrome of menopause, or GSM.
We really need to look at the mechanics of GSM to understand why PRP is so effective here. Because during menopause, the body's estrogen levels just plummet.
And estrogen is what keeps the vaginal and vulvar tissues thick and elastic, right?
Exactly. It keeps them supplied with healthy blood flow. So when estrogen drops, you get tissue atrophy. The mucosa literally thins out and loses its natural folds, which are known as rugae.
Oh, wow.
Yeah, the blood vessels shrink. And because arousal is fundamentally a vascular event, I mean, it relies entirely on tissue engorgement, the physical mechanism of sexual function just begins to fail.
That makes total sense.
And on top of that, childbirth can cause physical microtears or stretch injuries to the pudendal nerve, leaving localized scar tissue.
Right. And for a long time, the primary answer was just, well, systemic hormone replacement therapy or telling patients to go buy over-the-counter lubricants.
Right, which are management strategies, not restorative ones. PRP approaches the problem entirely differently. By injecting those highly concentrated growth factors directly into the clitoral area and the anterior vaginal wall, the VEGF forces the creation of new vascular networks.
So it naturally restores localized blood flow and the body's own lubrication.
Exactly. Meanwhile, those other growth factors go to work regenerating the damaged sensory nerve endings and rebuilding the collagen matrix of the thinned-out tissue.
Okay, but raising a very practical question for you here on behalf of anyone listening. If a clinician is injecting highly concentrated plasma into some of the absolute most sensitive tissue on the human body, doesn't that hurt? I mean, what kind of downtime are we talking about?
The clinical reality, according to the protocols we reviewed anyway, is actually quite manageable. The entire area is heavily pre-treated with a prescription-strength topical numbing cream, or sometimes they use a local anesthetic block.
Okay, so you're not going in completely cold.
No, not at all. Patients generally describe it as like a mild pinching sensation or a feeling of brief localized pressure rather than severe pain. But the aftercare protocol is where the underlying biology really shows its hand.
Yes, okay. There's a highly specific rule in the clinic guidelines that completely caught my attention. There's an absolute ban on NSAIDs.
Yes.
Patients are strictly instructed to avoid non-steroidal anti-inflammatory drugs, so things like ibuprofen, naproxen, or aspirin, for a full 7 days before the procedure and 7 days after. Why is that? I mean, ibuprofen's the very first thing you reach for if you have a little swelling from a procedure.
I know, it seems counterintuitive, but it comes down to how NSAIDs work on a molecular level. NSAIDs reduce inflammation by blocking an enzyme called COX-1, but platelets absolutely require that exact COX enzyme to aggregate, activate, and release their granules.
Wait, really?
Yeah, and furthermore, platelets don't have nuclei. They can't synthesize new enzymes. So if you take an aspirin, you permanently break that platelet's ability to function for its entire lifespan. If you take an NSAID right after your PRP injection, you are chemically neutralizing the platelets before they can even release their growth factors.
So you are stopping the exact biological process you just paid thousands of dollars to initiate.
Exactly.
That is wild.
Yeah.
You could ruin a highly advanced regenerative procedure with a single over-the-counter pill.
You really could.
But speaking of the recovery, the timeline for resuming normal activities is surprisingly short. The guidelines state you only need to wait 24 hours to resume sexual activity after an O shot. When you compare that to other treatments like ablative CO2 laser treatments for vaginal rejuvenation, the difference is night and day.
Oh, absolutely.
Because a CO2 laser literally drills microscopic holes into the tissue to trigger a healing response, and you have to wait 5 to 7 days just to avoid severe infection or permanent scarring.
Right. Because PRP is just an injection of your own fluid through a very fine needle. Once those tiny microscopic entry points seal up, the risk of infection is incredibly low. There are no open burns or physical tissue deficits to heal, just your own concentrated biology going to work.
So if PRP can rebuild surface tissue, grow new blood vessels, and repair damaged nerves, what happens if we go deeper?
That is the million-dollar question.
Right. Can this same mechanism actually rejuvenate entire internal organs? This actually leads us right into our second source, the massive systematic review on the use of intraovarian PRP for women struggling with diminished ovarian reserve, or DOR, and premature ovarian insufficiency, POI. We are talking about the absolute frontier of fertility treatment here.
What's fascinating here is that the scientific community is currently undergoing a massive paradigm shift in how we view the aging of ovaries.
Mhm.
For decades, the ironclad dogma was that females are born with a finite number of eggs, and when those eggs are gone, or when their quality degrades with age, there is simply nothing to be done.
It's just game over.
Yeah, right. But researchers are now realizing that poor ovarian response is often linked to a disrupted microenvironment, specifically microvascular insufficiency.
Okay.
Over time, the tiny blood vessels supplying the ovarian stroma diminish, literally starving the surrounding tissue.
So the environment itself becomes toxic, or at least like unlivable, for the dormant eggs that are still actually sitting there in the ovary.
Precisely. The quote-unquote ovarian niche becomes hypoxic, meaning it's deprived of oxygen and vital nutrients. Intravariant PRP aims to fix this. Clinicians use a long needle, guided by ultrasound, to inject the PRP directly into the ovary itself.
Wow.
And that massive influx of VEGF and PDGF triggers the growth of new blood vessel networks. It drastically improves the perfusion of the ovary, essentially trying to wake up resting follicles that were previously starved into a state of dormancy.
I mean, looking at the data in the systematic review, the numbers are just staggering.
They really are.
Some studies showed a 167% median increase in anti-Müllerian hormone, or AMH. And for anyone unfamiliar, AMH is a hormone secreted by developing egg sacs. And it's the primary marker doctors use to estimate a woman's remaining egg supply.
Right.
They also reported a 75% increase in antral follicle count, which are those small resting follicles that doctors can actually see on an ultrasound. And of course, the ultimate metric, live births, have actually been achieved in very poor prognosis patients following this PRP treatment.
It is incredibly promising data. It offers a biological mechanism to potentially rescue ploidy, which is the genetic quality of the eggs, by simply providing them a healthier, nutrient-rich environment to mature in before they are retrieved for IVF.
Okay, but looking at this from a critical perspective, it
Yeah.
sounds like we're just watering a dead plant and suddenly it's blooming again.
Right.
But if we're seeing 167% increases in AMH and spontaneous pregnancies in women who had lost all hope, why isn't every single IVF clinic on Earth doing this as standard practice?
That is the big question.
Because then I dug into the methodology section of this review, and honestly, it looks like absolute chaos.
Yeah, that chaos is the exact reason it isn't standard practice yet. The systematic review highlights a massive lack of standardization across the entire industry. You have to remember, this isn't a manufactured pill where every tablet has exactly 50 milligrams of an active ingredient.
Right, it's totally variable.
Exactly. This is a biological product, and right now, every single clinic is extracting and preparing it differently.
Yeah, the review noted that the volume of blood drawn varies wildly. Like one clinic might draw as little as 8 milliliters of blood, while another clinic draws 80 milliliters.
Which is a massive difference in the baseline starting material.
All right.
And the variables just multiply from there. The needles used to inject the ovaries vary. Most use a 17-gauge needle, but some use narrower, thinner needles.
Is there a problem with the thinner needles?
Well, the problem is they can easily get bent or blocked by fibrotic tissue, which is the dense, tough scar tissue that often forms on aging ovaries. If the needle gets blocked, the PRP just doesn't reach the target.
Oh, wow.
And then there is the activation method. Some clinics activate the PRP right before injection using a chemical called calcium gluconate at a specific 1:9 ratio.
Okay, and what does the calcium gluconate do?
It mimics the body's natural clotting trigger. It forces the platelets to dump all their growth factors immediately upon entering the ovary.
I see.
But other clinics use no activator at all. They just rely on the tissue's own collagen to slowly activate the platelets over days.
And the most surprising variance to me was the centrifuge equipment. The review stated that a manual double spin method actually yields vastly superior platelet concentrations compared to the highly expensive automated commercial centrifuge systems.
Yeah, the physics behind the double spin are crucial. The first, slower spin separates the red blood cells, leaving the plasma with the platelets suspended in it.
Yeah.
But a manual process allows the clinician to extract that plasma and do a second, much faster, quote-unquote, hard spin.
And that does what?
This forces those tiny platelets to form a dense pellet at the very bottom of the tube. They can then discard the excess platelet poor plasma at the top and resuspend that pellet in just a tiny fraction of fluid.
Wow.
That is how you reach the therapeutic sweet spot, which most researchers agree is a concentration of over 1 million platelets per microliter.
And the automated machines can't do that.
Automated machines often fail to hit that density. So, because clinics aren't standardized, one patient might be getting a super concentrated, highly active dose, and a patient at a clinic down the street might essentially just be getting a shot of mildly enriched plasma, which explains why the success rates are all over the map.
Right. And if highly trained fertility doctors at top-tier IVF clinics are struggling to standardize how to safely extract, concentrate, and inject these autologous blood products, it raises a honestly terrifying question about what is happening at the aesthetic clinic or the strip mall med spa down the street. Which connects us directly to the UK government's massive new consultation response regarding the broader non-surgical cosmetic sector. Here's where it gets really interesting.
The explosive popularity of treatments involving injectables, dermal fillers, and autologous blood products like PRP has created this booming multi-billion-dollar industry. But until very recently, it has operated with surprisingly little regulatory oversight in many parts of the world.
It's just wild.
It really has led to an absolute wild west of varying skill levels and safety standards.
So to finally rein this in, the UK government proposed a new licensing scheme and opened it up for public consultation. They received over 11,000 responses.
Which is huge.
It really tells you just how heated the battle over this industry has become. So they are proposing a strict 3-tier risk system to categorize every single procedure: green, amber, and red.
And the tier system is based entirely on the potential for patient harm. So the green tier is for the lowest risk, superficial procedures. Think microneedling or superficial chemical peels. Any practitioner, assuming they meet agreed-upon baseline standards for hygiene and basic training, can perform these.
Makes sense.
Then, the amber tier represents medium risk. This means non-healthcare professionals can still physically perform the procedures, but they require direct oversight by a named, regulated healthcare professional who actually has specific qualifications in prescribing medication and managing medical complications.
Okay, and then there is the red tier.
Yeah.
Highest risk. The government is proposing that these procedures are so complex and inherently dangerous that they are being pulled completely out of the local licensing scheme entirely. They will be brought under the strict national regulation of the Care Quality Commission, or CQC. They can only be performed by suitably qualified and regulated healthcare professionals.
Right. And this 3-tier proposal has ignited a fierce, very high-stakes debate between two distinct camps, which the consultation document outlines in great detail. And we should clarify, we aren't taking sides here, just looking at what both sides are arguing in the source.
Absolutely. We're just laying out the arguments.
So on one side, you have the aesthetic practitioners, often referred to in the industry as non-medics. They argue quite passionately that a medical degree does not inherently make someone a skilled aesthetic injector.
Right.
They argue that a general practitioner or an emergency room nurse might spend their days managing blood pressure or treating infections, whereas a dedicated aesthetic practitioner studies facial symmetry and performs dozens of specialized cosmetic injections every single day.
Yeah. And then on the other side of the debate, you have the medical professionals. They argue that pushing a needle into human tissue and injecting foreign substances or even concentrated biological material is a fundamentally invasive procedure. Their argument hinges on what happens when things go wrong. If you are injecting dermal filler and you accidentally hit a facial artery, you cause what's called a vascular occlusion. The filler physically blocks the blood flow to the tissue, which can literally lead to permanent blindness or localized tissue death necrosis within hours.
That is the absolute crux of the medical argument. A non-medic cannot legally prescribe medication. So if a vascular occlusion happens, you need to instantly inject prescription hyaluronidase, which is an enzyme that dissolves the filler to save the tissue. Medical professionals argue that true public safety requires deep anatomical knowledge and the legal ability to instantly prescribe and manage severe emergency complications.
And the government's push for this regulation isn't just theoretical or, proactive. It was catalyzed by a deeply tragic event detailed in the consultation response: the death of Alice Webb. She passed away following a non-surgical Brazilian butt lift, or BBL.
So awful.
This tragedy sparked a massive public campaign for what is being called Alice's Law.
It brought the severe, life-threatening risks of deep tissue injections into stark focus. Procedures involving massive volumes of dermal fillers injected deep into the tissue for breast augmentation, genital augmentation, or buttock lifts carry extreme risks if the practitioner misjudges the anatomy.
Right.
If that filler enters a major deep vein, it can travel straight to the lungs or heart, causing a fatal pulmonary embolism. Because the stakes are literally life and death, the government is making it a priority to push these specific deep injection procedures firmly into the red tier, effectively treating them with the exact same gravity as invasive surgical procedures.
It's a really sobering reminder that just because a marketing brochure labels a procedure as non-surgical, it absolutely does not mean it is non-invasive or risk-free.
Definitely not.
And speaking of protection, the consultation showed overwhelming support for introducing strict age limits across the board.
Yes, the government is moving to restrict all these licensed cosmetic procedures to people over the age of 18. There is a deep systemic concern about the pressures of social media, filters, and influencer culture on developing bodies and
Oh,
minds.
for sure.
The consensus from both the public and medical professionals is that young people who are still developing emotionally and physically must be protected from making permanent or semi-permanent alterations to their bodies based on just fleeting algorithmic cosmetic trends.
Unless, of course, the procedure is specifically approved by a doctor for a genuine medical reason, like treating severe scarring from an accident. But the baseline rule for cosmetic tweaks would be 18 and over.
Right.
So if we look at everything we've explored today, the journey of regenerative medicine is just incredible. We're looking at a biologically powerful tool that leverages the construction workers inside our own blood to heal. It is being used to restore intimate function, rebuild structural tissue, and even wake up fading fertility by oxygenating starved organs.
But as the UK's regulatory scramble shows us, powerful tools require precise instructions and strict safety guardrails. Whether it is an IVF clinic trying to standardize the perfect double spin rate for a centrifuge, or a government trying to figure out who is legally qualified to hold the syringe, the law and the medical establishment are just now rushing to build the framework around a technology that is already out in the wild.
And as we move forward, regenerative medicine is increasingly going to rely on our own biology, our own plasma, our own stem cells as the actual medicine. It's not a chemical synthesized in a factory. The drug is you.
Which leaves us with a fascinating question to consider as this field explodes. If the quote-unquote drug is simply your own harvested and processed blood, where exactly does the law draw the line between a strictly regulated medical device and a natural autologous healing process? Should your own biology be regulated by the government the exact same way they regulate a pharmaceutical? Will the future of medicine be something we buy from a lab, or will it be something we simply harvest, refine, and redeploy from within ourselves?
That is a deeply provocative thought to leave on. Thank you for joining us on this deep dive.